collect all this collective information and say, okay, we need to come up with label changes and say, do not take vitamin B12 with when you are consuming this particular suspect drug. So that information comes up when you look up at the aggregate reports. Okay, and this particular trail of event happening continuously over time is called a signal. And when you detect this particular signal in a particular fashion, it is called signal detection methods. This is another department. Now you are in the case processing department, you would be handling single cases and case clusters. Now there'll be a separate department which does aggregate reports. Yet another department which does signal detection. And there's a different department which does risk management effectiveness. Now, what does this team do? They look at your signal detection, this particular signal, and they are going to come up with a RMP or a plan on how to mitigate this risk that has been happening. How are you going to tackle it? How are you going to prevent it? Like I said, you come up with label adjustments, advising patients not to consume vitamin B12 when you're taking this particular suspect drug A. So those are your risk mitigation plans, and that is done by a risk management team. So these are the different departments other than case processing that would help in analyzing the benefit risk profile of the drug. Now, what are the different types of reporting? One of the most common types and what you are trained on in MediPharmSolutions is expedited reporting, also known as ICSRs. Another method of reporting is periodic reporting. Like I explained in the previous slide, what falls into periodic reporting is aggregate reporting as well as risk mitigation plans or REMs. Now, these reporting are done over a period of time, every 6 months, every quarterly, every annually, something like that. They'll have their own timelines and plans to do it. On a daily basis is what you do, expedited reporting or ICSRs. Now, in expedited reporting, when do you do expedited reporting? First of all, expedited reporting is expected to have a compliance of 95% and above. If your pharmacovigilance team has a compliance below 95, they're not efficient enough, and 95 is the lowest. You should always aim at being 98% compliant. And which are the cases that get qualified for expedited reporting? Your case should be serious. What is the criteria? First of all, your case should be serious. Then it should be an unexpected event. Okay. And it should be suspected as an adverse drug reaction by the investigator as well as by the sponsor. Both of them should agree. But the most recent update which has come out, especially for this batch, which is going to go ahead for the interviews, is initially, first let me explain of how it was previously. When you are dealing with cases coming in for submission to the European Union, the European Union would accept any case which is serious, unexpected, and the investigator says it is suspected. That was more than enough for the EU to accept the case. But when it comes to FDA submission, the FDA required that the case is serious, it is unexpected, and both the investigator and the marketing authorization holder both should agree that this is a suspected adverse drug reaction. Only then you would qualify to submit for the FDA. But the most recent change which has come up is now FDA and European Union both are in sync with each other, and both of them agree that at a clinical trial site, whatever the investigator says is the final say. Now, if your case is serious, it is unexpected, something that has not been recorded from your previous clinical trials. This is a new adverse event that is coming, and it is serious and it's life-threatening. Okay. If the investigator says, yes, I suspect this particular event happening because of our suspect drug that is more than our